Rita from Zurich, who is already on. We shall bring her in a short while. So 2 presentations will not be given. The presentation by Dr. Kadivane, he had to leave as an emergency back to Nairobi. Unfortunately, we don't have that presentation here with us. And Dr. Muturu Ndungu has also not showed up, so those 2 presentations will not be given. And Dr. Mustafa will present on behalf of Dr. Mwika. And then at the end of this session, there will be a raffle organized by Harley's Farmer. We shall give them just 10 minutes to conduct that raffle, and they'll be giving presents to the winners. So with me to chair this session is Dr. Musau. He will introduce himself, and then we can take it up. We shall have a Q&A session at the end of all the presentations. So keep your questions and have them at the end. So I will introduce our first speaker. Professor Rita Gobet is a pediatric urologist based in Zurich, Switzerland, has been a partner with of cows for many, many years, and she's the one who introduced or initiated the Professor Rita Gobet Awards for the best resident presentation, and has offered to continue to support that program. As I've said, she's a pediatric urologist, now retired, and we're always glad to have her in. So Professor Rita, if you are ready, we can proceed.
Can you hear me now?
Yes, we can, Prof.
Hello?
We can hear you, and we can see your presentation. Go ahead.
Fantastic.
Pleasure to meet you.
Hello from Switzerland. Sorry?
Carry on. We are happy to have you with us.
Thank you for the nice introduction. It's great to see you all healthy and very busy, and congratulations on your 25th birthday. It's too bad I didn't get a piece of cake, though. I watched the meeting yesterday, the whole day, and I have to say I very much enjoyed the panel discussion about the pediatric stone case. That was really, really superb. Dr. Osawa suggested another topic for my talk, so I'm going to talk about hypospadias redo surgery. Yeah, but first I want to show you some pictures. This was the view from my balcony for a couple of weeks. And then came the really cold weather. You see, this is a place where people usually go to swim in the summer, all covered with ice. I hope these pictures make you understand why I not only miss you, people of Kenya, but also the wonderful climate in Kenya. But now, let's start with my presentation. In preparation of my talk, I looked up on YouTube the subject, and I can really recommend several videos of presentations there, like this one from Warren Snodgrass and Nicole Bush, which was held at an Egyptian meeting, as well as this one, that's Professor Ala El Ghoneimi at the same meeting, and Then I found another one from India, Professor Kulkarni and his people, and I can really recommend. I think that's one of the advantages of this COVID era, that you find a lot of good presentations online. I want to talk about redo hypospadia surgery. That's talking about complications. What kind of complications do we see? Unsatisfactory cosmetic results. These are mostly circumcision problems and are quite easy to deal with. Fistulas with or without distal stenosis. And here I think it's important to discriminate between the coronal location versus others. Stenosis, diverticular, dehiscence, either just of the glands or then a complete dehiscence, recurrent or persistent chordae, or, and that's the most difficult problem, complete failures, or as people call them, call this also hypospadias triple, a very ugly word, but it describes the truth. Hypospadias correction, are we as good as we think? This is a review of proximal hypospadias primary repairs, and you see that even big centers, Toronto, the Sick Kids, Boston, Texas Children's Hospital, and the CHOP, they all have very, very high complication rates. Ala El-Ghanemi and his people conducted a review. It's quite old, 10 years ago, but I think nothing really has changed, comparing the different types of reconstructions, and they came to the conclusion no urethroplasty technique is definitively superior to others. Complications. The percentage you find in literature varies widely between people who say I have 1% versus 70%. Of course, this percentage depends on the type of hypospadias. Something that is clear also on patient's age. So the younger the patient, the less complication, the lesser the risk is for complications. That's one of the reasons why we still think that correction of hypospadias in early age, that's below 2 years, is still advisable. But also it depends, of course, on hormonal and genetic factors of the patient. Then it depends on the type of procedure. There are specific complications for some procedures, and of course, of the surgeon choosing the right procedure for a certain hypospadia. Then, of course, the percentage depends on the surgeon himself or herself, his or her experience, and also the possibilities that he has. Depends on the instruments, sutures available, and loops. And very important, it's clear, the percentage depends on the length of follow-up. The longer you follow your patients, the more complications you're gonna see. How do you prevent complications? Well, the easy thing is do not operate. And I'm pretty serious about this, certainly in distal hypospadias. I think parents need to be really, really well informed. I still see here in Switzerland, parents who come to our hospital and say, well, the pediatrician has said this needs to be operated. And I think this is not true. I think you have to really inform the parents very well, tell them that there are many men living a happy life with a hypospadias, even not knowing that they have a hypospadias. This is, of course, true only for distal hypospadias. I was always impressed also in your setting how these parents come and bring their little children for a really distal hypospadias that they can live with without any problems, but they want to have surgery. So I think this process called shared decision-making, which describes how you talk to parents and make sure that they really, really understand the information you give them and then make an informed consent. This process is very, very important. Then, of course, it depends how do you prevent complications by getting better and better at what you are doing and also improve your post-operative care. The surgeon exposure and experience of the surgeon is very obvious. The more you do, the more experience you get, the better you get. And in order to do that, most people would recommend to stick to a few methods, not do something different every time. Of course, you should use fine instruments dedicated to hypospadias surgery. And I think that's an area where Kenya can make progress. Use fine sutures, use loops. Tissue handling is very important. And I think that's why pediatric urologists or people dealing with delicate tissue should do this, and not an adult surgeon who is doing a hypospadias every now and then. Of course, you need to have appropriate catheters. You need to make sure that you have a safe and competent post-operative care, including good pain management. Long-term follow-up is mandatory because only then you can see your results really, and what is of utmost importance, record your results, especially your complications, and learn from them systematically. The patient, it's important to choose the appropriate age to do the surgery. It's of course better if the patient is informed and consents. If that's possible, the patient should be healthy, check for underlying problems, DSD, for example. And what has been shown clearly now is that preoperative testosterone treatment does not help to decrease your rate of complications. Redo hypospadias surgery is mostly very difficult and is prone to create more complications. The preoperative workup, I always try to watch the child pee. I go with him and his mother or father to the toilet, and then I can see the stream and the dribbling. You can also do uroflowmetry, but in children, sometimes this is a little scary and you don't get the real pictures. You should consider urethroscopy, certainly in more severe cases. Retrograde urethrography is only indicated, in my opinion, in very special cases. For distal hypospadias, it's not helping. Think about PXO. Many complications are caused by this awful disease. Then you should, if you can, preoperatively also check on erection. Usually the parents can provide a photo for you. Then it's important to wait at least 6 months from the last operation. And then again, it's very, very important to discuss in depth the options with the patient and the parents. So there are people saying if you have a recurrent curvature, it's better to wait until puberty to fix it then, because you don't know the effect of penile growth on this curvature. What I find sometimes that if you started from a distal hypospadia and get a coronary fistula, it's better to go back to preoperative state instead of causing more trouble. But this has to be discussed upfront with the parents in depth. Principles of fistula repair, you all know them. Always check for distal stenosis. I always fill the urethra intraoperatively with saline to see the fistula. Sometimes you get surprises and see then more than one. It's important to close the urethra with inverting stitches. Try to have a multiple layer closure, no overlapping suture lines. There is discussion about the small incision versus midline incision, degloving only if you need to do a circumcision revision anyway. And this YouTube video that I showed you from Snodgrass, he emphasizes in that video that you should check for recurrent curvature in all cases, because he feels this tension on the tissue on the ventral side of the penis might be a reason for recurrent fistulas. Of course, you know that fistulas come in all forms and shapes. Very often it's this subcoronal location, which is quite difficult to fix as opposed to the fistulas on the penile shaft. There you have much more tissue to cover your defect. I was talking about the access. When I started doing this type of surgery, I learned the smaller the incision, the better. I'm not so sure about this anymore, if this is the correct way to fix a fistula. You get a much better exposure with a midline longer incision. In this case, we even found a second fistula, so you don't want to miss this. This is a picture from Ala El Ghonemi. He gave me the permission to use it. This demonstrates a case with a weird looking fistula where he decided to go back to the status of before surgery. So he just opened up here this tract and closed it here and left the child with a coronal meatus again, and the child and the parents were quite happy with it. Sometimes you have to admit it, that you didn't succeed. An interesting variation of fixing these things is the cuff procedure. This is a nice example also from Ala. He opened up this fistula here and found the distal urethral plate to be unhealthy, almost non-existent, but had a very nice healthy urethra and a short gap. So he decided to mobilize the urethra, you can see that here, and bring it up to the tip, and got a nice result. So this is something to keep in mind, of course, only for special cases. Glans dehiscence, it's important to really develop nice glans wings. You mobilize the glans wings all the way along the corpora to get a tension-free closure. Urethral diverticulum, check for distal stenosis, and they are known to be very frequent after onlay repairs. But this is a nice thing because they are easy to repair. You know this, you see the diverticulum here, quite big. And when you open it up, you have a huge mass of tissue available for your reconstruction of the urethra. Sometimes I even think, oh, I wish I could keep this for another or the next patient. So this is not really a big problem from the surgical point of view. Oops. Persistent curvature. As I said before, Snodgrass thinks that you need to check for it in every complication because this might be a reason for that. I'm not sure what to think about that, but I wanted to let you know. Ala Elgonemi thinks that you should wait until after puberty. And of course, very often it's associated with other problems or complications, or so they are complete redo cases. So this is a case of persistent curvature. So what do you do? Some people recommend to do a redo dorsal plication if the curvature is less than 30 degrees. Of course, you can modify your dorsal plication by doing something almost like a Nesbit, but not really taking out tissue, but joining two incisions on the dorsal side of the penis. But most people would say, and certainly for more than 30 degrees of curvature, you need to do a ventral procedure. And here also the discussion is out how to do that. I learned to do one corporotomy on each side and fill this defect then with dermis tunica vaginalis or SIS. But more and more people are using different approaches. Like Pipi Sully, he recommends to do very many, up to 20, 30 very superficial incisions. And some people do then some sort of physiotherapy postoperatively to stretching of the penis. Others, like Snodgrass, he now recommends 3 deep incisions and covers the whole area, not the defect only, but the whole area with tunica dartos or vaginalis. What about redo urethroplasties? A redo tip alone is probably not a good idea, because why would it stay now that you have a scar already? So most people would recommend, if you want to tubularize the urethra in one step, to do an inlay graft. But in most cases, you will need a 2-stage repair with a graft, or even a 3-stage repair. 3-stage, because if you need to fix the recurrent curvature first, then you can't place a graft on another graft. So this is the principle of the inlay graft. You incise your dorsal, your urethral plate, so that you get a really wide defect. This needs to be at least 1 centimeter. You cover it then with buccal mucosa, and then tubularize the urethra, and you get a nice urethra, very wide and with a better chance of healing. The 2-stage repair is not different from the first. If you do a primary case, of course, you won't have the foreskin, so you have to use in all cases buccal mucosa, which is very easy to get also in children. you cover the defect, and then 6 months later you come back in size along your graft, tubularize it, and then hopefully cover it with several layers and hopefully get a good result. I found in the literature people saying that in 40% of patients you get this sort of results. This is not my experience in children, so maybe we are lucky that we deal with children. In my experience, if you remove all scarred tissue, you almost always get a good result in the first stage, but then, of course, again, the risk for recurrent fistulas, etc., after the tubularization. With these ugly pictures, I wanted to change. Now in Switzerland, it looks like this. The flowers are out, the sun is out, and it's 20 degrees. Thank you very much for your attention and stay safe. Asante sana.
Thank you, Professor Govet, for the wonderful presentation. We appreciate that you're quite far from here and you might be having other commitments. So we were thinking that unless you say otherwise, we are going to get 1 or 2 patients so that we don't tie you so much.
It's okay, I'll stay
You'll
for
stay.
the pediatric session anyway.
Thank you, thank you.
Yeah.
So the next presenter will be Dr. Bob, who is going to talk to us about the management of testicular torsion, a multi-center analysis of factors affecting successful testicular salvage.
Good afternoon, everyone. My name is Dr. Faith Bob. I'm a pediatric surgical resident, postgraduate level 5. Today, I'm here to present to you on a multi-center analysis on factors affecting affecting successful testicular salvage. And I decided to do this survey because this is actually an issue that we have as a country and also as a center of excellence that actually deal with testicular torsion and testicular salvage. So as a way of introduction, I would like to say that testicular torsion is a very common pediatric emergency, and it occurs the prevalence is around 1 in every 4,000 male patients by the age of 25 years. It is the most common cause of testicular loss in United States, and we actually don't even have current data that shows the rate of testicular loss in Kenya. Testicular torsion has both short-term and long-term consequences. And the long-term consequences that is actually the elephant in the room is actually male infertility. And we know that male infertility, especially in Africa, has been quoted to be around 40% among all males. And among all heterosexual couples that actually have infertility, 30% of this of the cause of infertility is actually from the man, from male. So and that is why when you have a patient with testicular torsion, there are 3 important issues that we need to deal with. 1 is early presentation. 2 is early intervention, early diagnosis, and 3 is early intervention. And if there is any gap or any mishap in any of these 3, we are likely to have an increased risk of testicular loss. And that is why today my objective was to look at the factors affecting testicular salvage. And I did not restrict myself only to Kenyatta National Hospital, but I also took my data from other facilities, including mostly the referral hospital. So what I did is I used a questionnaire that I distributed among doctors in these facilities, and this was actually shared online to them. And the target centers was Kenyatta National Hospital, Moi Teaching and Referral Hospital, Kisii Level 6 Hospital, Jaramogi Oginga Odinga, Nakuru PGH, Coast PGH, Level 5 hospitals, and also other Level 4 hospitals. So what was I looking at when I was doing this survey? Number one, I wanted to look at the age of presentation. And from my survey, actually found that majority of the patients were actually between the age of 12 and 18 years old. That accounted for almost 75%. The next common age group that was affected was male patients between age of 8 and 12 years, and accounted for 38%, and this actually fall within the pediatric age group. I did not find any from these centers, any patient who presented below the age of 8 years. And also, but in Coast PGH, they actually reported a male patient who presented with testicular torsion at the age of 42 years old. I also looked at the pre-hospital time, and this is actually important to us, as we know, because we were dealing with testicular salvage. And it is actually sad that most of actually our patients from the survey presented, 61% of these patients presented after 12 hours. You can see between 8 to 12 hours, 19% after 8 hours, and after 24 hours, we had 38%. So if you look at this population here, between the ones who presented between after 8 hours, or between 8 and 24 hours, is actually more than 61%, which actually makes the majority of patients. So we should ask ourselves, why are our patients presenting late? Is it that the issue is a health-seeking behavior, or the issue is the socioeconomic status, or the geographical distribution, or even in availability of health? And those are the questions we should ask ourselves. And that is why we also looked at the referral. So most of these patients find the information was being taken from referral centers. So most of these patients, actually 71% of these patients who presented with testicular torsion in these centers were actually referral patients, and 28% were actually presented to these hospitals at the first hospitals. So this is also another area that we know for sure with the referral system in our country that is likely to also increase the pre-hospital time, from the time of the onset of pain to the time of presentation to the hospital. And another thing that also affects our health-seeking behavior is availability of medical insurance, be it NHIF, private insurance. And from this survey, we can see that it's only 23% of patients who actually present in these public referral hospitals who have NHIF. And up to 76% of patients do not have any insurance, be it private insurance or NHIF insurance. And this we know from previous literature, or from literatures that have been done recently, that this really affects the health-seeking behavior of our patients. So we can actually yeah, we can actually say that in availability of insurance, I can comfortably say also causes a delay of presentation. So as I said, after presentation, the most important thing is actually very quick and prompt diagnosis, and this is both from clinical and colored Doppler ultrasound. And from my survey, this was actually a good finding. We found that most of these centers have actually have ultrasound that is readily available at 76.2%. And when I say availability of ultrasound, I mean the ultrasound and someone to do the ultrasound. So after diagnosis, you want prompt intervention. And prompt intervention means detoting these two testes as early as possible. And actually, we know from our literature, it is recommended that detortion should be done at least before 8 hours. But unfortunately, from my survey, you can see that actually most centers do their surgery or perform the testicular scrotal exploration or testicular detortion after 12 hours. And from my survey, actually 38% perform after between 12 and 24 hours. And another 23% perform actually these surgeries after 24 hours, that is after 1 day, which accounts for almost 23%. So from this survey, we can only see just a very minority group, that is 23%. This is 4.8 and this is 19%. So around 23% of our patients, or the patients we see, actually get or rather undergo surgery within the first 8 hours. And that is why there's several factors that have actually been documented in our literature and in previous studies that have been done both locally and internationally that have identified risk factors or factors that directly affect testicular salvage. And one of them is age. Being a pediatric resident, I will not fail to mention that pediatric age group are actually at higher risk of getting testicular loss or orchidectomy. It's testicular torsion. And this is because they present with unspecified or unspecific symptoms that actually, for most of us, or for the primary doctors, don't really put it as high, really don't think about testicular torsion when a patient presents to them with these unspecified symptoms. Healthcare access. I mean, we are in a developing country, and we know healthcare access is not readily available, especially in some parts of our country, and this also affects the testicular salvage. Another thing is socioeconomic status, and socioeconomic status. Patients who come from low socioeconomic status, and even this was from a paper that was done by Murithi et al. They actually found that patients who come from socioeconomic status are likely to have testicular loss and less likely to have testicular salvage. Also, availability of experts or expertise to do.
Can you summarize? Your time is up.
Okay, thank you. And expertise to actually deal with this. And also other factors include geographical distribution and accessibility, and also availability of insurance. So prompt surgical, from this survey and also from literature that have actually been done normally, we have seen that we only have 14% testicular salvage currently in our country. And this was actually done from a paper that was done by Murray et al. Of the Aga Khan Hospital. And also there's a paper that was done by Murithi and Mati et al., which reported that testicular salvage among patients with testicular torsion is only 17%. This is not comparable to what we have in the world, where we have only testicular salvage in almost 50% of our patients, of patients internationally who present with testicular torsion. So in conclusion, I can say that we as a country, from the data I collected from this survey, we can say that we have a very low rate of testicular salvage. And this can be attributed to the late presentation and the late surgical intervention amongst our patients. amongst our patients who present with testicular torsion. So what can we do as an organization? Number one is we need to raise awareness, because we are dealing with something that can actually affect, or rather something that actually affects infertility, and this actually even is a risk to our survival as the human race. I mean, if we have infertility levels of that.
Wait, Bob, I'll have to stop you, sorry.
Yes,
Time
okay.
is up.
All right. All right, okay. And also, we need to come up with management protocols. Thank you.
Thank you very much. Thank you very much. Okay, please let's keep time. We're already behind schedule. Our next presenter is Dr. Siovata Francisca. And she will be talking about trends in management of disorders of sex development, currently being referred to as variations of sex differentiation. Thank you.
Good afternoon. I'm Dr. Francisca Silvata, as I've been introduced. I'm a level 5 pediatric surgery resident at the University of Nairobi. So my topic is the trends in management of DSD in Kenya, disorders of sexual differentiation in Kenya, and how it compares to the rest of the world. So DSD is a congenital condition with atypical development of the chromosomal, gonadal, and the anatomical sex. Its incidence worldwide has been noted to be at 2.2 per 10,000, but in Kenya we do not have exact incidence. The mainstay of management of DSD is actually individualized treatment of the patients, which is brought about by having a multidisciplinary team. And from that, from initiation from an MDT team, then we can be able to structure the diagnosis and management of these patients. So it's broadly classified into 3 based on the karyotype. That is the sex chromosomal DSD, the 46XX DSD, and the 46XY DSD. Then the rest of the subclassifications fall under the 3 of them. As per our local data, I'll start from a bit far back, from January 2003. So Dr. Kihiko et al. Did a study on DSD at management practices of DSD at Kenyatta National Hospital, and we were able, and that was the period between January 2003 and December 2013. And in this study, they were able to find that, yes, it's rare in Kenya. 2, there is no uniformity in the protocols of investigation and management of these patients. And 3rd, we cannot access all the investigations that are required for managing these patients. So I went ahead and did a retrospective study and on the description of management of DSD in Kenya, and I followed it up from January 2014 to December last year. I went through the records department at KNH and was able to fill a data collection sheet. So in summary, I'll be able to highlight a few, some of the results that are found. Out of the age of presentation in Kenya, most of the patients we get come at around the age of 1 to 3 years. And most of them are actually below 3 years. More than 60% of the patients, when you combine from the neonatal, the infancy, and 1 to 3, they make up the majority of the patients. However, we have another spot of patients which come during the puberty, and others also come past 18 years in adulthood. Okay, so for the range of investigations that have been done in Kenyatta, we find that hormonal profile and the electrolytes, these are readily available in Kenyatta, and are some of the tests that are being done, which is easily accessible. Before, like the 2014 to 2015, we can be able to see that they do the bar bodies. Currently, it's not recommended because we have the karyotype, and it's actually commendable that we were able to do in most of these patients. Readily available imaging like ultrasound can be able to tell us if there are any features of Mullerian features in the pelvis. Other investigations are like the laparoscopy. As you can see, we've moved away from laparotomy as a mode of investigating, and we are at laparoscopy and also gonadal biopsy if need be. So out of all the patients that had done karyotype, 45% of them had 46XX, 35% had 46XY, and the remaining 20% had sex chromosomal DSD. And this we had a few cases of Turner's syndrome and Klinefelter's syndrome. For the surgical management and how we've been managing these patients, what was commendable is that all the patients that we operated on were not, it's only one patient that we operated on at 2 years of age. I'll come to explain this. The rest of the patients, we were able to do the surgeries past puberty. So the most common investigations that we were able to do were urethroplasties and orchidopexy. The next was a gonadectomy. This is for the patients who have already been decided that the current gonads that they have are not functional for them. There's a patient who, a 20-year-old man who came in with 10-year history of persistent abdominal pain, and upon laparoscopy, they were able to find a uterus and clots in the pelvis. So for that patient, what we did was a total hysterectomy. There are also tests such as surgical management such as vaginoplasty and clitoroplasty for the patients that we've decided to do a feminizing surgery. So this is an example, a picture of a case of a patient. It's a female patient who had clitoromegaly, but presented at puberty, 16, and we were able to reduce the size of the clitoris, open up a septum that was covering the vestibule, and give them a feminine exterior genital. So where are we currently at Kenyatta National Hospital? A centralized multidisciplinary team has been formed 2 years back. It comprises of pediatric surgeons, gynecologists, the pediatric endocrinologists, psychiatry, the nurses, and a representative from the ethics. So this team has been able to follow up patients, and from there we are able to structure and the full management of these patients. Second, we delay the surgical management, as I'd explained. We do this with the consent of the patient. So the patient must be of age to actually give an opinion and their feelings about the surgeries that you're about to do, because they are permanent. So what are the challenges that we face in Kenya? Currently, there are cultural and social factors which put a lot of stigma in these patients between them and the greater society. Coming to the cultural and the societal factors, worldwide, the Eastern countries have a different protocol compared to the European countries. The European countries have a structured protocol. For the Eastern countries, they prefer a male gender assignment. This is because probably of the role, the gender role that they play in the society. And also within us, the culture, we look at these patients as if they're outcasts, and they might actually inhibit their access to healthcare. Second thing is the access to investigation. This is both availability and financial capability to actually do them. The karyotype examination actually takes about 35,000 and above. We don't have policy to manage these patients, because once we have to do a gender reassignment, it's very difficult to actually change the name of a patient who has been brought up as a female and to change as to a male. Even getting an ID is difficult. You find that the KCPE, they are registered as female, and the KCSE, they're registered as male, and aligning those two is difficult. We actually have a problem with the long-term follow-up. Half of the patients that I saw were lost to follow-up, which is quite alarming, because now they come back when the secondary sexual characteristics starts forming. And also the transition of care, we need to have 20-year-olds go to the appropriate clinics, and we need to hand them over and not to follow us at the pediatric clinics. So according to the international guidelines, this is an example of a protocol of management, the investigations of the patient. Mainly involves the laboratory blood works, the imaging, and laparoscopy. So depending on following the graph, we can be able to decide what is the subsequent management of the patient. So for gender assignment, outside the country, it's recommended to assign this gender within 48 hours of time, this of life. The surgical management, I've already...
Please wind up.
Okay. Surgical management after puberty, the risk of gonadal tumors. So we look at what kinds of tumors they have. The highest risk are those with testis-specific protein Y, which is able... So such for the recommendation for the high risk is gonadectomy. Steroid replacement should be aligned to the growth spurt of the patient and also the development of the secondary sexual characteristics. What is key outside is to have a psychosocial support to follow up this patient from infancy all the way till adulthood. So what are my recommendations? One, that we have already formed a centralized MDT, which is good. Before, we used to have, yes, multidisciplinary team, but it used to be the patient to walk around in all the different kinds of clinics. So having them centralized aids us in our management. We need to engage the government and explain to them and give them awareness so that they may be able to identify these patients as individuals and also cater to the needs that they may actually require later. Patient support groups will help in minimizing the stigma and also all the challenges that they go through. It can be with all of them. And public awareness, where we can be able to pass the information to the rest of the public, again, to reduce the stigma. Thank you. That's my presentation.
Thank you, Salvata. Our next presenter will be Dr. Gohil. Dr. Gohil. Dr. Gohil is going to tell us about the utility of ultrasound examination in detecting undescended testes, a multi-center study in Kenya.
Good afternoon, everyone. My name is Untitled Gohil, and I'm a level 4 pediatric surgery resident at the University of Nairobi. So I am going to be talking about the utility of ultrasound for the diagnosis of undescended testes in Kenya, a multi-center study. Because undescended testes is one of the most frequent disorders of the genitourinary system in male infants. It's crucial to identify whether a viable testis is present, and if so, either perform an orchidopexy or an orchidectomy, because leaving a testis in an undescended position increases the risk of occult malignant degeneration in the future, infertility, torsion, and or an inguinal hernia. So due to that importance of identifying the viable testis, most healthcare workers are asking for imaging, and we need to educate on the utility of the imaging modality and whether it is useful or not. So as the migration of testis through the inguinal canal occurs relatively late in gestational development, cryptorchidism is accordingly higher in premature boys in the first few months of life. So we need to know that gestational history is very critical. The prevalence of undescended testes in premature male infants is about 15 to 30%, and in term infants it's about 1 to 3%. So the most useful determinant of management for cryptorchidism is whether the testis is palpable on physical examination or not. We need to have an accurate pre-surgical diagnosis of the undescended testis to spare the child an operation and to have a correct localization of the testis so as to limit the extent of surgery. So I did a survey. I did a study to determine if the primary respondent requested for imaging to help make a diagnosis of cryptorchidism and to determine the factors associated with that decision. It was a prospective cross-sectional study that I did, and I created an online survey form using Google Forms, which was filled by healthcare workers from multiple health facilities in Kenya. So these were my results. As you can see from the pie chart, most of the respondents were medical officers and residents from the pediatric department. And of note is that these two cadres of healthcare workers are the primary care providers for children in our country. Also, when I was doing the workshop here in Kitui, we found 2 patients with undescended testes, but on physical examination, they apparently did not have the undescended testes. However, the ultrasound did say that the testis was undescended. With regards to the years in practice of the respondent who had taken the survey, majority of the respondents worked in Nairobi, which has a population of about 4.3 million people, and most of the respondents, that is about 86%, worked in a hospital-based setting. So this is the most important pie chart. The one question that asked about whether the respondent ordered imaging, and 80% did order for the imaging, 10% were unsure, and 10% did not. According to this pie chart, according to the survey, most ordered the ultrasound on a usual basis, and ultrasound was the commonest imaging requested. Regarding the factors that led to that decision of ordering for imaging, these were the factors such as presence of non-palpable testis, bilateral undescended testis in a child more than 1 year, and to provide reassurance and assist the surgeon in planning the operative approach. With regards to the question about whether a genital ultrasound distinguishes undescended testis from retractile testis, 50% said no, and about 34% said yes. The other interesting findings that I got from this survey was examination or mention of the state of testis at birth is confirmed to be done at the hospitals by only 44% of the respondents, and this is a contributing factor to the delays in management. The cost of ultrasound, as per the survey, ranged from 800 to 3,500 shillings, depending on the facility where the respondent worked. So, as per this survey, ultrasound has turned out to be the most heavily utilized imaging modality used. Yet, we know that the sensitivity and specificity of this imaging modality is only 45% and 78% respectively. So, this is these are some papers that I came across. This one was by Jumailal YA in Saudi Arabia, where he did a retrospective study of 46 patients who underwent an inguinoscrotal ultrasound preoperatively between June 2007 and June 2012. He compared it with intra-op findings, and he found that only 67% of the intra-abdominal testis correlated with the preoperative ultrasound, and only 65% of intracanalicula correlated with the preoperative ultrasound. So this was another paper by Majors et al. In 2007 that reported that ultrasound failed to identify all 14 of the viable intra-abdominal testes when using 5 to 12 megahertz and 7 to 10 megahertz transducers, which meant that Even with the current advanced technology, ultrasound cannot reliably localize non-palpable undescended testes, which comprise about 20% of all undescended testes. This was a systemic review of about 15 studies published in 2011. It assessed the diagnostic performance of preoperative ultrasound for undescended testes, and they found that it performs poorly as a diagnostic test and that it would not change the surgical management. Ultrasound does not differentiate a non-viable nubins from the surrounding inguinal testis, surrounding inguinal tissue, and the bowel gas often precludes the localization of the undescended testis. Hence, they recommend that ultrasound for intra-abdominal testis has a low specificity and sensitivity of about 44% and 93% respectively, as shown. So regarding the other associations like the American Association of Pediatrics and the American Urologic Association, as well as the European Association of Urology, do not recommend the use of ultrasound or any other imaging modalities. In fact, the American Association of Pediatrics emphasizes that infants with a history of neonatal cryptorchidism who do not have a spontaneous descent by 6 months, corrected for gestational age, should be referred to an appropriate surgical specialist for timely evaluation.
Please start summarizing. Yes. Your time is close.
So to conclude, I hope these study findings that I did will be able to show and improve on the educational updates for referring providers, especially the younger practitioners and those not practicing in the academic environment. Because remember, in the hands of an experienced surgeon, more than 70% of undescended testes are palpable on exam, and they need no imaging. So to summarize, if you get a patient with an unpalpable testis, the ideal thing is to take a detailed physical history, including a gestational history, then to have a thorough physical exam, and then do an examination under anesthesia. And if the testis is still unpalpable, we can do a diagnostic and therapeutic laparoscopy. Thank you.
Thank you, Dr. Hetal, for attempting to keep time. Okay. Our next presenter is Dr. Said Abubakar, and he will be giving a talk on acute urinary retention in children, as seen at the KNH. Please, you have 10 minutes.
Good afternoon. I'm Dr. Said Abubakar, Level 4, Pediatric Surgery, University of Nairobi. I'll be presenting today about acute urinary retention in children as seen in Kenyatta National Hospital. So, acute urinary retention in children is a relatively clinical entity, rare clinical entity. But it constitutes a genitourinary emergency. So it requires high risk of consequences. Yes. The etiology of acute urinary retention are poorly defined in literature, though there is the etiology, it ranges from trivial causes to severe diseases and sometimes malignancy. So with the consequences or severe consequences that we may expect, it requires a prompt diagnosis and treatment. Also, the etiology of acute urinary retention among children, it differs from adults. By definition that we used in our study was that acute urinary retention defined as inability to empty bladder voluntarily for more than 12 hours with urine volume greater than the expected for age or bulbable distended bladder. In my study, I wanted to review the cases that presented to Kenyatta National Hospital with acute urinary retention. So I will look at aspects at demographics, etiology, and management. So it is a retrospective cross-sectional study for the children who presented to us with acute urinary retention. And the data was collected from the medical records of Kenyatta National Hospital for the last 5 years. So I will present here about the results. It was a total of 22 cases where we could retrieve only 16 files. According to the incidence and distribution, the number of cases by year, it's almost equal, especially for the 2017, 2018, and 2020. They were, each year we used it to admit 4 cases by year. And 2016 and 2019, it was, we have admitted 2 cases presented with acute urinary retention. So we can understand from there that that it is a rare clinical entity. Looking at the sex distribution, here we found that the majority of the cases, about 2/3 of the cases, were male patients, which may explain that there is significant anatomical difference between male and females. So that, and also related to the etiology. Looking at the age groups, we have also found that those children who were younger than 3 years of age were the commonest age group who presented to us. And also we find here that the incidence of acute urinary retention in children decreases with increase of age, and so on. We can relate more of the etiology to those related with congenital conditions. Coming to the etiological causes, according to the by gender, here, yes, yeah. So here, according to these are the male patients and these are the female patients. The colors are near to each other. So we found in our study that most of the causes of most of the etiology of acute urinary retention in children were mechanical obstruction. Posterior urethral valve, the commonest, then the bladder masses, bladder stone, strictures, paraphimosis, constipation. These are the about reaching 80% of the cases of the etiology was related to mechanical obstructions. Here also, also here what we can find is that the cases that presented with acute urinary retention secondary to UTI was just confined to females. Coming to the management of acute urinary retention, all the patients presented to us with acute urinary retention, we are admitted for further investigation and treatment. First, the urinary bladder was drained, either urethral or suprapubic catheterization, and the measurement of the residual volume. Then, conducting of comprehensive physical examination related to the pathology, local pathology, and related also to the consequence of the pathology. So also looking, including the examination included also neurologic, lumbosacral, and external genitalia, initial workup was done for the all patients that we had admitted, including full hemogram, urine analysis, and the chemistry panel. All of them looking for the consequences of the obstruction, distal obstruction. What we found is that KUB ultrasound was the first and the commonest modality that we have started with our imaging. That gave us a hint or a lot of related to the obstruction in terms of the look in the bladder, either the pathology up to the tract, the ureters and the kidneys. Then other investigation modalities like CT scan, MRI done but required. In bladder drainage, what we have achieved, approaching to 87.5% of the cases, we could drain the bladder with the urethral catheter, and only 12.5 patients had been catheterized suprapubically. In acute urinary retention, the patients who presented with mechanical, as the majority of the cases, as we have said, about 80%, including posterior urethral valves, including bladder mass or stone, urethral strictures, traumas, strictures secondary to traumas and paraphimosis, were managed after the diagnosis, were managed surgically. The other cases, urinary retention secondary to urinary tract infections and fecal impaction, where there was a case of presented with fecal impaction, we have managed it non-surgically. Coming to the discussion, what we have seen in our study, we have tried to compare with what is available in literature, also regionally or internationally. So what we have found is that there was similarities for the most studies that have been done. Here, there is a study that has been done by Amihai Nevo et al. In Israel, shows the similarities to our study. So they found the similarity about the male predominance, which was also significant in their study, and in acute urine retention among children. Also, what they found is that mechanical obstruction was the most prevalent cause. Etiology about a ratio, about a percentage reaching up to 80%. There was also significant difference in etiologies that we have noted according to the gender that we have noted in our study also. Constipation also is a known association with voiding dysfunction according to this study that has been done in India. So our take-home message here is that acute urinary retention is an uncommon condition, but at the same time, the delay in the diagnosis may result as serious consequences that will affect the life of the children. Yes, the other important thing is that male predominance has been noted. So any male child who presents with acute urinary retention is that we have to look for any pathology, any underlying pathology. Mechanical obstruction was the commonest in our study, the commonest etiology in our study. So that's another take-home message. Acute urinary retention secondary to urinary tract infection also was confined to female. That it doesn't mean that they can't present, but the majority will be in female patients. Ultrasound is the first imaging modality in the assessment of the acute urinary retention in children. Thank you.
Thank you, Abu Bakr. You've kept your time. Our next presenter is Dr. Ismail. Dr. Ismail, you have 10 minutes. And Ismail will be discussing or giving a talk on spectrum of penile trauma in children at the Kenyatta National Hospital. 10 minutes.
Good afternoon, everyone. I'm Dr. Ismail Hassan, level 5 pediatric surgery resident. And the topic I'm going to present is pattern of pediatric penile injury at Kenyatta National Hospital. The reason why we chose this topic is because penile injuries have grave consequences on the children's life, in boys' life, and majority of the cases are preventable. So we want to highlight the etiology of these penile injuries and some of the management that we did for patients who had severe cases of penile injuries. So we did a retrospective study of all pediatric penile injuries managed at Kenyatta National Hospital for a period of 7 years. And our inclusion criteria was all patients with age 13 years and below who presented with penile injuries. And so the result we found out that is that we had 39 patient boys with who presented with penile injuries during the study period. The mean age at presentation was 5 years.
Ismail, your slides are lagging behind. Just catch up with the slides, please.
Okay. Yes, thank you. So the mean age was 5 years of age, and this is in contrary to in literature where most other places where they do neonatal circumcision, most of the complications of penile injuries are found in the first year of life. And so we divided the patients in 6 main etiological groups. And these were patients who had circumcision-related injuries, 26 of them. We will discuss this in details a bit. And animal bites, which we had 1 patient who had donkey bite, in contrary to the usual literature we see of dog bites reported in literature. And physical abuse and sexual abuse, and we had 2 cases. These were in cases who had patients who have been insulted by adult patients who are the caregivers. And we had 5 cases of zipper injuries. 4 of them were minor injuries, prepucial injuries. 1 case had urethrocutaneous fistula, and because the zipper was removed at home where they used to try to use force. We had cases of mutilation. These are cases who had penile strangulation. This can either be in patient accidental, where the child plays with threads, bands, hair ties on the penis, or we had 1 case of a patient who did this because of had nocturnal enuresis, so it's trying to tie the penis so that you can prevent urination at night. And so the higher percentage of these patients who had penile injuries were patients who had circumcision-related injuries, which were 67% of the total. And the most common complication related to circumcision was, of course, the benign bleeding and wound infection. But apart from that, the major complication was urethrocutaneous fistula. And we had 2 cases of penile glans amputation. We had 1 cases of total penile amputation in our series. So what we found is that the circumcision-related cases, we had 26% of these patients, and 26% of these patients were circumcised by professional peoples and who were healthcare professions, and 74% of these patients were done by unprofessions. So from this discussion, from this result, you can see that the cause and the type of penile trauma varies from minor issues as entrapment with zipper to serious penile loss and total emasculation. In our study, we found that 67% of the penile injuries were related to circumcision, and this high incidence is correlated to the usual practice of a ritual circumcision in our country. The same has been found in areas where ritual circumcision is practiced, in Egypt and in Nigeria, most of the African countries, Israel and Turkey. So Salim et al. From Egypt had came up with criteria of grading post-circumcision penile injuries, and had grade 1 as a skin deficiency, grade 2 as isolated urethral injuries, grade 3 as partial or complete loss of glans, grade 4 as amputation at the level of the shaft, and grade 5 as total phallic loss. So this grading is significant in terms of surgical undertaking. Also in our series, we found that 3/4 of the circumcision patients had urethrocutaneous fistula that were primarily repaired. So in management, all penile injuries, other than very superficial injuries, are recommended to be evaluated with retrograde urethroplasty to exclude concomitant urethral injuries. The findings of expanding hematoma, palpable corporal defect, excess bleeding suggest cavernosal injuries. And when these possible injuries are suspected, primary debridement and primary repair can be done, either with urethral diversion or achievement of catheterization after repair. The preferred method of management is of these penile wounds is extensive debridement with surgical and repair of the cavernosal defect. And the question comes up, how do you deal with the penile skin loss? And if you can see that picture, we had a patient who, 7-year-old male, who was a street kid who came to us with a total loss of penile skin after mutilation by people in the street. And so the best form of cover for this kind of injury is normally full thickness skin cover, and predominantly because this is an erectile tissue that we need flexibility and durability, and that we will not be able to get from a split thickness skin graft that might have contractures. And the place of choice for probably picking this full thickness skin graft are areas where you don't have hair growth, especially. And if you can see, we have taken this graft from the lower anterior abdominal wall, just above the inguinal crease. You can also take it from mid-thigh or the gluteal region. So we did the grafting for this patient, and it took well. Our second patient is a patient who had circumcision was done in a health facility, and patient bled profusely, and they thought they had amputated the glans, and they did a mass closure of the penis. So, and then they proceeded. The patient developed a urinary retention, and suprapubic catheter was inserted. So by the time the patient came to us, we had, if you could see the first picture, just a stump that was covered by skin. And fortunately, we took the patient to theater, and after exposure, we found that the gland had retracted. And so luckily for the patient, he had the gland saved. And so the issue was a skin cover, so we still used full thickness skin graft that we also got from the anterior abdominal wall. We have cases of glans amputation, currently 2 of them, and we have not so far, they are currently, we are following them up just in a period of 6 months. And this patient, one is the one I talked about of a donkey bite, who was a referral from Wajir, and so had a donkey bite while herding animals. So we are currently planning on way forward. The options for these patients are normally glans reconstruction using a graft and covering it with a buccal mucosa. And So cases of penile amputation, so far we had managed one case. We had a total phallic amputation, and what we used for this patient was a penile elongation technique, where we degloved the remaining stump, had a little bit of an anterior corporal length remaining, which we freed and cut the suspensory ligament. Some part of the posterior corporal ligament pulled up, and we managed to create we managed to create a stump that you can see. 1 month postoperative, that is the last picture on that. So in conclusion, and most people, and as you can see, most of the cases are circumcision-related injuries, and in our region, this is most common because of a ritual circumcision practice, and most people take circumcision to be a minor procedure, but the consequences are grave. So our take-home message from today is that circumcision is a procedure that has to be learned by everyone, and should not be assumed. And the role of this society can be, first of all, awareness. And as you have seen, that 26% of these cases were done by professions, that is healthcare workers. So awareness to and education to how safe circumcision can be practiced. We can also be involved in ritual circumcisions, where we know the times they are being held and the areas that normally practice ritual circumcision. We can offer them training on how safe circumcision can be done for those the elders who do the circumcisions. And we can also offer our expertise in training and advice for these cases. Thank you.
Thank you very much. We are moving on to Tim Jumbi. Dr. Jumbi. Dr. Jumbi is going to present on the predictors of treatment outcomes of Wilms tumors at KNH.
Thank you very much for this opportunity to stand before you again. I'm going to do a presentation on Wilms tumor. And this presentation, I'm doing it, but it's really a collaboration by many specialities, because there's a group of pediatric oncology stakeholders that have come together to try and improve the Wilms tumor outcome in these pediatric patients. And so there being no other conflict of interest, I wish to take you back to last year, where I did a presentation on the clinical pathological behavior of the Kenyan Wilms tumor. Now, the Kenyan Wilms tumor has been studied before in collaboration with Kijabe Hospital, with MTRH, and Vanderbilt University. And what we have established is that this Kenyan Wilms tumor is different in its behavior, particularly in treatment resistance. And so we have been collecting data prospectively through this group. And what we thought of doing this year is to try and look into the predictors of these factors that can influence this treatment resistance. And so there's this review article which was done by Dome et al. In 2015. And he was able to pick up some of these predictors that may lead to treatment resistance. That's patient age, tumor size, volume, tumor stage, tumor histology, and loss of heterozygosities. Now, this has been published in literature, and most of the Wilms tumor papers will have this as the predictors and prognostication factors. And so we set out with the same cohort study. Last year we had 28 patients, so we've been able to increase about 27 patients to a total of now 55 patients that we have in our database of patients who have Wilms tumor. And just to look at the clinical characteristics, this is what we have in our KNH database. And just so that we can compare to literature, we are almost the same in terms of age distribution, in terms of gender, and also in terms of laterality. The age right here might be a little bit off, but still within the range of the incidence of Wilms tumor. Now, in Kenyatta National Hospital, we do use the COP protocol to manage Wilms tumor, and this means that we give chemotherapy in advance, then we operate later. Now, for us to know whether there has been any tumor response to the prior chemotherapy, we need to look at the initial imaging, and we need to look at the initial size of this Wilms tumor. Now, this is an international collaboration criteria. It's called the RESIST criteria. It was developed in 2000 and later updated in 2009. And it basically gives these four categories of how you can classify the response to treatment of solid tumors. Now, because of objectivity and reproducibility, we thought of using this criteria just to bring this into our study, just to see whether our tumors are responding. And so our cohort database was 55 patients. Unfortunately, we could only analyze 28 of these patients. This is because for 27 patients, we are missing the baseline size. This means that the patients came with a CT scan that was not indicated the initial size of this tumor, and so we cannot get a response rate out of it. So we are going to do this 28, and for this 28, 22 were chemo-responsive using the RESIST criteria, and 6 of them were chemo-resistant. In fact, 3 of them progressed, so that means that they actually increased in size from the initial imaging. And with that, we looked at these predictors. Now, I have to mention that there is a study limitation because of this missing baseline size and the fact that we are missing molecular profile in all of our patients. This means that that predictor called loss of heterozygosity we cannot test within our patients. When you look at the results, I hope that slide is not too busy. Our counts are low, so we are only working with 28 patients. So we used a Fisher's exact test to try and bring out some subgroup analysis. And as you can see, none of these p-values are significant. I want to repeat that we are only using 28 patients. And so the subgroup analysis cannot be conclusive to these p-values. Of interest is look at the volume of these patients. So most of our patients have very huge tumors above 1,000 cc's. The other thing is, despite these big volume tumors, most of them are actually of favorable histology. And when you look at the staging, stage 3 and above, I decided to dichotomize this staging. Stage 3 and above means that the tumor is outside the renal capsule and it is metastatic or either bilateral. Most of the tumors we have are actually within stage 1 and stage 2 tumors. So our objectives were partially met because of these limitations. So we had low counts for subgroup analysis. We are missing a lot of baseline information on initial size, and we cannot get the molecular profiles of this tumor. And so really the message that I want to pass across here is, number one, we need to take our level of predictorship and prognostication to another level where we can actually test these predictors of outcome. When we do that, we are able to bring our multimodal therapy in Kenya targeted to our Wilms tumor, because right now we are using the therapy that is based on the tumors that have been studied by the COP and the COG protocols. We have already established that our tumors are different. So if we're able to get this, then we'll be able to move forward. Now, our prospective series is key on this. We started 2 years ago, that's in October 2018, and we are moving forward. So we have a huge database, which we hope that by 5 years, we can comfortably say that this is our 5-year outcome for Wilms tumor. But of course, as we go ahead, we need to use the data that we have to try and look into our standardization on imaging. So the Kenyatta National Hospital team and the radiologists have been able to create a standard practice, which they have promised to share it out there, so that even these patients that are referred to KNH already have the standard imaging findings if they did the CT scan out of Kenyatta. Again, we have a team on pathology who are willing to look into the standardization of the histology reporting. Remember, I mentioned that right now they are only mentioning whether the tumor is favorable or unfavorable. The COP protocol has gone further to go into the molecular characteristics of this tumor. And finally, we need the molecular profiling in our setup, which is not being done. Thank you.
Thank you, Dr. Tim. Dr. Tim is one of our younger consultants now. He's not a resident, so whoever is marking the papers should take note. He's our third born. Our next presenter will be Dr. Mustafa. Dr. Mustafa will be presenting on behalf of Dr. Peter Mwika, who was unable to be here with us. Dr. Mustafa, you have 10 minutes.
Okay. Good afternoon, everyone. My name is Dr. Mustafa. I'm a third-year pediatric surgery resident in the University of Nairobi, and I'll be presenting findings on the impact of COVID-19 pandemic on clinical and academic urological practice in Kenya. So the unexpected coronavirus disease of 2019, which was declared pandemic in March 2020, has spread worldwide rapidly, developing into a global health crisis. At the same time, this pandemic has seriously impacted the daily activities in all fields of urology. So this survey was aimed at better understanding the impact of COVID-19 pandemic on the clinical, educational, and research activities in the field of urology in Kenya. So my data was collected from KNH theater records during the era of COVID, that is March to December 2020, and in the same period, 3 years prior to this era, which was 2019, 2018, and 2017. We also designed an online questionnaire which was targeting consultants and residents in departments of pediatric surgery, urology, and general surgery in various hospitals around the country. So these were my findings. You will note that there was a decrease in the total number of urological cases done at Kenyatta National Hospital. There was a steady decline all the way from March, with a peak drop in September, and there was a mean drop of about 36.7%. Of note is that during the last 3 months of the year, you'll notice there was a slight increase. There was a slight increase in the number of urological cases that we did in Kenyatta National Hospital. This is owing to the fact that there was reduction in the stringent COVID restrictions. There was a lifting of a ban of inter-county travel. That's why we had an increase in the number of urological cases during the last 3 months. So this is a summary of the total urological cases that we did in the year 2020 all the way to 2017. Of note is that there was a 43% decrease in the total number of urology cases in 2020. We used to average about 200 cases of urology in the previous years, and during this era of COVID, we did slightly higher than 100 cases. So this is a chart summarizing the academic hours. So what we did, each urological procedure was assigned academic hours as per the university curriculum, and these hours were tallied for the period of study. We noticed a mean drop of about 37% in the academic hours. Just like the others, we also noted improvements as the COVID restrictions were eased towards the end of the year, with a peak of 29 academic hours in December 2020. So these were the respondents of our online survey. There were surgeons and residents in the Department of Pediatric Surgery, as I mentioned, urology and general surgery, with the distribution as shown, with 81% of our respondents practicing in public teaching and referral hospitals. So this is the effect of the pandemic on bed occupancy and theater booking. There was a reduction in urology bed occupancy in the hospitals, according to 79.2% of our respondents. And most of these respondents attributed this to hospital management prohibition in 74% of the cases. In some hospitals, these beds of urology were actually assigned to COVID-19 patients. So 84.9% of our respondents reported cancellation of elective theaters in their hospital. This is the effect of COVID-19, availability of COVID tests and theaters. We noticed that in 47.2% of the respondents said the institutions, the preoperative pathway for patients awaiting elective surgery involved performing COVID-19 confirmatory tests for suspected cases, while a similar amount performed the COVID-19 test on all patients routinely. 76.9% of institutions, we noticed that they don't have a specially equipped COVID theaters, while only 15.1% of the respondents had access to PPE all the time. Majority of our respondents, about 45%, reported that they only had access to PPEs, personal protective equipment, only 45.3% of the time, occasionally. So on the academic activities, we remember that there was a circular from the university whereby there was a ban on physical classes. There was a limit to the number of people who would attend ward rounds. There was this, together with the reduction in the number of patients, informed our respondents to note that there was a negative impact in the academic and scientific activities, with 88.7% confirming this, while 69.8% of the respondents have been forced to cancel their travel plans to scientific meetings and congresses. On the flip side, we noticed that 90.6% of our respondents had conducted meetings, online and lectures, meetings, lectures, and grand rounds online, and about 64% of these respondents had presented an abstract, a lecture, or a workshop remotely. So what is my take-home message today? The data collected in this survey provided valuable information about the changes that occurred in clinical and academic settings in Kenya. So there was a negative impact on surgical and clinical urology practice in Kenya, with a significant reduction in the total academic hours of urology. The COVID-19 pandemic negatively affected scientific, academic, and educational activities in the year 2020. However, there's a silver lining to all this. On the flip side, there was an increase in the number of classes, seminars, and presentations that were done online. An example is our COWS presentation this year, whereby we've had both local and international speakers, including our very own Professor Gobet, who we were lucky enough to share their experiences without having to travel all the way despite all the restrictions. So this was a positive thing that came out during this COVID era. So in conclusion, I would like to say that there was a significant impact of COVID-19 pandemic on the clinical and academic urological practice in Kenya. And finally, I would like to thank the Department of Health Information Records, and most importantly, I would also like to thank my respondents for the questionnaire, majority of whom are seated here, for sharing their responses. Thank you very much.
Thank you, Dr. Mustafa, for keeping time and finishing your message delivery within half the time that you allocated. The next person is Dr. Osawa, who shifts from being a panelist to a presenter. We hope that he will be able to keep the time that he has been expecting of others.
It's quite a challenge. I have to take quarter of the time because my resident has done half. So I'll try. Thank you very much. Thank you. I want us to just look at issues related to the parents of some of our clients or patients in pediatric urology. And therefore my title is Effects of these surgeries, primary and recurrent, on parental anxiety at the Kenyatta National Hospital. have no disclosures. So the background of this study is based on documented facts that procedures in pediatric urology may generally cause distress and pain in children with consequent negative effect in terms of their behaviors and recovery. And the distress and fear status caused by these medical interventions have been investigated previously and found to really contribute to significant levels of anxiety on their parents. And of course, that has got an effect on our patients' recovery phase. Right, so parental anxiety by definition involves excessive worrying about the potential problems that their children might go through, or the wrong things really that might happen to these children after surgery. And according to those two authors, there's a single risk factor such as that parental anxiety may predict a wide range of negative outcomes. And I've just highlighted a few of that. They tip on off the family dynamics and have effects on pain scores on these children, and sometimes creates a barrier for the parents to care for their children. So worldwide, the reported incidence of anxiety in children undergoing surgery overall, not just urological surgery, is reported at between 50 and 75%. So predictors of these anxieties include the age of the child, type of surgery, gender, occupation, level of education of the parent, and baseline anxiety of the parents and previous surgeries. And the known strategies for dealing with this include adequate information regarding these procedures, the plan of anesthesia and surgery, pain management, information about complications of these procedures. So we embarked on really a survey that involved talking to parents of patients that we saw between August and December of last year. And of course, most of our patients were males, and majority were falling within the age of, between the age of 1 to 5 years. And majority of our parents, again, were between 20 and, between 20 and 29 years. Now, on the other side, that might not be very clear, but the first chart here is a chart on just get it again. Right, we were looking at the age of the children. We were also looking at but this is not one of the most important images that we wanted to see. Sources of anxiety. This is the most important slide that I want all of us to look at. When we inquired about the sources of anxiety, the biggest issue was lack of information on the surgery, okay? And then the possible dangerous effects of anesthesia, and then the outcomes of surgery. Pain was well on top, but not the most important one according to this survey. And then we found out from the parents, we asked them what, in their opinion, what would we do from our side to relieve that anxiety bit. And again, what came out clearly again is the issue of information. Okay, 60% of our parents indicated that if they were given adequate information on circumstances around the procedures on their children, their surgeries would be, I mean, they would have be less anxious. And then information during the surgery. Basically, 71% referred to issues of information. And if you remember, even Professor Gobet earlier on was emphasizing on talking to the parents about issues of outcomes and issues that are surrounding surgeries for hypospadias as one of the most important aspects of care for these children. So this study found that 98% of our parents are actually anxious in the period when we are dealing with their children, okay? And this is comparable to an Athens study which I came across, which is almost 80%. But the top reason being information. And what has been noticed, according to the well-validated anxiety scores that are used mainly adults, but have been also used in to assess parents, that is the Amsterdam Anxiety and Information Scale Score, and the Anxiety Visual Acuity Score, and the other one, the STY score. Information. Availability of information forms part of the most important parameters in these tools. Okay, and evidence by this gentleman shows that provision of information helps to reduce fear of unknown, and in turn reduces the perioperative anxiety on our parents. So what perioperative information is then important to pass to these parents? A study in Spain in 2015 actually confirmed and proved that the most important information to these parents is that they need complete perioperative information about anesthesia, about surgery, and about post-operative care, and it has to be verbal and well in advance. You don't get to inform these parents after you have done your procedures. So, having looked at our figures and literature, then we can safely say that parental anxiety is widespread amongst our parents and undergoing urological procedures, and can be mitigated upon by provision of complete perioperative information in advance, well in advance. Thank you very much.
Thank you, Dr. Osawa. If your intention was to do better than your student, you failed it twice. So we come to the conclusion of the presentations, and we are moving on to the question and answer session, where we'll be getting questions direct to the specific people that you would like them to address.
So in view of time, I think we'll limit the questions to, I think 3. Professor Gobet is still online, so if anybody has a question for Prof. And then at the end of it, we shall have a quick draw by Harlis. We shall give them 5 minutes. Harlis Pharmaceuticals, can you move closer? We shall give you only 5 minutes because we are running behind schedule. So any questions for any of the presenters, please? Let's go. Dr. Otele, then Dr. Wambani. Dr. Juma Irungu.
Thank you, Chair, for the session. Dr. Gobet, you hear me? Professor Gobet?
Yes, I do. Thank you.
Thank you for attending this session. I wanted to ask you about repeat urethroplasty post hypospadia, whether you rate it as the same as hypospadia in a child who is circumcised. In my limited experience, I think that they are the same, because that lack of foreskin and previous surgery and related fibrosis, it's just like previous surgery. So if I'm revising, I'll put the same patient who has been circumcised in the same category. I'd like to invite your comment on that particular aspect. Thank you.
Thank you for the question. Yes, I think you're right, because in a circumcised patient, you don't have the inner prepuce to use as a free graft, or if you prefer the flaps, it's the same. I think what's different is they don't have all the scar on the ventral side of the penis. So that makes reoperation of a hypospadia, in my opinion, more difficult than when the patient is just circumcised. But as I said, you're right, you need to use buccal mucosa. I think that's the thing to do.
Thank you, Prof, for the answer. Maurice?
I have two questions, one to Dr. Ismail and another one to Team Jumi. Ismail, regarding your spectrum of penile trauma, I realize there is no mention on burns as a cause of penile trauma, and there's this other curious type of penile trauma where either children themselves or their parents tie the prepuce in an attempt to treat a nocturnal enuresis, and that causes trauma. Can you just comment on that? Then Team Jumbi, team like father, like son. Williams tumor, you know, your father did a dissertation on this 40 years ago, I think 40, 41. You were not born. I've read that dissertation. And I just want you to tell me what has changed regarding predictors of treatment of Williams tumor 40 years down the line. I'm sure you have talked to your father before you came here.
Okay. Do we allow Tim to answer straight? Okay. Tim, go ahead. Be brief, please. Don't go back 40 years ago. Just be brief.
This is Ismail first, Doc. Thank you for the question. And about penile injury due to burns, I think there are significant cases of them, but they are handled by our colleagues, plastic surgeons. And Dr. Nacha, on penile reimplantation and better place to answer that, because what we are looking for in our study is the patients you handled in our unit as a pediatric surgeons. And the second question.
Second question was for Tim.
No, the other question, actually, he addressed it, Dr. Wambani, about children tying their penises to mitigate against nocturnal neurosis. We saw some cases. Yes, Jumbi?
Thank you very much, Dr. Wambani, for that question. Indeed, I looked at the presentation, rather the dissertation done by Gadhaya Jumbi. And when you look at what was presented that time and what we have now, in terms of the socio-demographic characteristics of patients with Wilms tumor, it is indeed exactly the same. And that's really interesting to see that over the changing trends, the socio-demographics have remained the same. Now, what has changed is, number one, something about the diagnostic modalities that have been used then and now, because right now the diagnostic modalities are more targeted on what you want to see before treatment and after treatment, and diagnostic modalities to try and get recurrence and relapse situations of Wilms tumors. The other thing that has changed through the years, of course, is the protocols of neoadjuvant chemotherapy and radiotherapy that have changed through the COP9 criteria that started years ago to this time, when they are using the umbrella protocol to try and look at the molecular characteristics of Wilms tumor. They also look at the weight of the Wilms tumor, and they use these two characteristics to determine which patient is going to benefit from which kind of management. So there's an arm that will receive radiotherapy, there's an arm which will only receive surgery alone, and there's an arm that will benefit from all the multimodal use of therapy. The other thing that has come out very key within this generation is the use of multidisciplinary teams in the management of Wilms tumor. So every patient from the word go, from admission, a multidisciplinary team comes into play to manage this team, this patient as a group rather than individual specialities. Thank you.
Dr. Juma Irungu.
Mine is not a question, but rather a comment on Francisca Ziovata's presentation on threats in management of DSDs. Apparently, you either didn't mention it or I didn't hear it, that in this country, one of the emerging threats is the acceptance of a third gender. And the government went ahead actually and counted 1,700 and something Kenyans who are neither assigned any one of the genders in the national population census. And therefore, the government said the pace in the recognition of such people, and this has given strength to either activists or proponents of the third gender, that the patients or the clients should be involved in decision making as to what gender they should be assigned to. Now, these children actually are not given that opportunity. And therefore, as clinicians, we need to be aware of that, and that maybe as we assign gender, we may be actually inviting litigations in future. I think those of us who can remember, I think there was a judge that apologized for assigning a prisoner to committee for quite a long period of time, and the gender wasn't very clearly defined. So mine was that kind of a comment that as clinicians, we make these decisions on gender assignment. It's good to be aware that there is this upcoming trend of accepting a third gender. Thank you.
Yes, Dr. Irungu, I think she was very clear at the end of her the conclusions that we are now moving towards doing these reconstructive procedures when the children are older enough to make their own decisions. Okay, so that is already taken up in our programs. The other one is a bit controversial and very, the issue of the third gender and activism, so I think we'll not get into that, but you're right. Burning question from Dr. Mugalo. I think that will be the last one.
My first question is to Dr. Bob. There was always this old teaching that you better get a negative scrotal exploration than miss a torsion. So in your study, is the delay because of waiting to get an ultrasound, or what was really, or delay in referring? And then my second question is to Professor Rita. She said that for distal hypospadias, you really don't need to operate. How distal? And I think we have a big task trying to convince our people you don't need to.
Okay, if Professor Rita is online, we shall start with her, then Bob will answer.
Okay, yes, I am. Yes, I am online. Well, I think what's important is that the urinary stream is sort of in the direction of the penile axis. So it can't be perpendicular, or I mean, it can be, but this usually is a source of troubles for the boys and the parents. But if they are in line with the axis of the penis, then at least in Switzerland, many parents are very happy if we just do the hemi-circumcision, remove the unsightly foreskin, and then nobody really cares if the meatus is at the glans level. I think if it's on the shaft, it's a different thing. And can I make a very short comment to you, Francis? I think what's also important is to make sure that your parents understand the information you give them. Thank you.
Thank you very much. Just before Faith, Dr. Mugalo, there is one time we were invited to see a group of patients in Kisumu who are undergoing voluntary male circumcision. And the reason we were asked to go there is that about 70%, I think almost 50%, let me not say 70, of those adults, they were adults, some of them were young adults, some of them were married, had some form of hypospadias. So I don't think it's such, I think there are still quite a number of people who are living with this condition out there that we are not aware of. Maybe the changing medical landscape is what is getting them closer earlier than before. But there are still many, many who are living with the conditions of distal hypospadias. Yes, Dr. Faith?
Yes, thank you very much, Dr. for that question. From my survey, there was obviously a delay in the time of operation from the time of presentation. But my survey did not go into detail to find the exact reason as to why there was a delay in that. But also, just to comment, is about the availability of ultrasound and use of ultrasound. From, as you said correctly, that clinical presentation and physical examination is enough actually to diagnose testicular torsion. That rightfully said, recommendations actually even from the EUA guidelines is that on physical examination and clinical presentation with physical examination is enough in diagnosis of testicular diagnosis of an acute scrotum testicular torsion. So yes.
Thank you very much, everybody, for attending this session, and thank you, Professor Rita, for gracing our occasion from Switzerland. Happy greetings from Kenya. We are winding up this session. Is Dr. Icol in? As Dr. Icol is coming up, please, Harley's Farmer, can you conduct your business in 5 minutes? Because we are really, really behind schedule.
Randomly, then you read the name.
I pick randomly.
We have 12 gifts.
You open. Dr. Awath Mohammed. Is Dr. Awath Mohammed here? I think he's the first lucky winner.
Swiss military torch. Okay. Yeah, multifunctional with the Bluetooth. Okay. Thank you so much.
If you are never my friend, you are in trouble. Okay. How many gifts are there? 12 gifts. So 12 lucky people. Abdallah Manzigo is rigging. Okay, let the chair. The chair says there is no regional balance here. All right. Now even there is no regional balance here. Yvonne Karimi. That is rigging, eh? Yvonne is not here. Somebody who can pick on her behalf, please. No regional balance again, picking on her behalf.
Gold-plated, it's a gold-plated set, cutlery set.
Gold-plated cutlery set. You can even pick for yourself. You can. Misango, you'll be the next to pick, don't worry. And make sure you pick your name. Dr. Owila Francis.
It's an ultraviolet raised disinfectant box. Yep, it also has a wireless charger.
For disinfecting your razors. Thank you very much, Ms. Sango. The elephant in the room. Dr. Jeremiah Njogu. Jeremiah Njogu. Yeah, you are also the elephant, don't worry.
It's a power bank, 10,000 mAh, with 2 USB ports.
Power bank, okay. Kimani.
I could pick mine.
Yeah, that's what I wanted to do. And then now the rest will be. So this one is contestable. Dr. Kasim Abdallah, sitting right next to you.
It's the same ultraviolet disinfectant box with the wireless charger.
Thank you very much. Please make sure you choose my name. I think the residents are not lucky here. Dr. Maurice Wambani. Maurice Wambani.
Yeah, it's a disinfectant. Yeah, UV rays.
Do you have anything to sterilize, really, Maurice? You can donate. You can donate if you have nothing to sterilize. Okay. Yeah, somebody from outside the. Who is from Kitui County? Oh, she's there. Okay. Now I agree with all of you. There is rigging. There is no regional balance. I think we have to start afresh. Yes. Dr. Mustafa Omar. Iko juju inatoka pwani. Tukoroge juju. How many more? You know, I might be giving out 4 more. My friend, your turn will come. Don't worry. Don't worry. What was your name again? Who is Roslyn? I just Roslyn. I can't. I think this is a spoiled vote. It's not Kenya, it's just Roslyn. Who is Roslyn? Okay, all right. Okay, well, somebody to pick for her, Roslyn Kenya. James? Oh, there she is. Sorry, what was your name again?
It's a gold-plated spoon set.
What was your name again?
Rajesh.
Rajesh. Gold-plated spoons. Gold-plated spoons set. She wants a photo. Oh, okay. I don't know. Okay. Okay. Wapi mtu wa Kisumu hapa? Wila ni wa Nairobi. Okay. Hakuna? Wahinya is from Kisumu, I'm told. Even Wahinya is from there. So let him just. Thank you. I think we have 3 more, or 2 more. Can't even read it. Oh, I've read it. Finally. North Rift. Edward. I don't know what you're going to get, but I hope they are gold-plated spoons. What will you eat with that? Power bank, power bank, power bank, power bank. I need a lady now to pick again. Finally, 2 more, eh? 2 more. There's a lady behind here. Please choose my name. Thank you. For those of you who are sinners, no gifts. No gifts. This was very close to my name. James Osoro. James Osoro, and finally, let Dr. Irungu, who in his inaugural cows meeting, make a choice. Power bank, eh? Yes. Thank you very much. Thank you very much, everyone. Thank you very much, Highlights. And now, James.
Okay, thank you very much. I am sulking because I did not get picked. Halis, I am very angry with you, but anyway, don't worry, but Nasibu. We'll bring you some more. Thank you. So let us break for lunch. I would request that we have a 30-minute lunch break so that we come back for the last session of the afternoon. We still have a lot of interesting papers to listen to. Thank you very much for your attention.